90, the suicide rate has doubled in the 15 to 19 age group and tripled in the 10 to 14 age group. Suicide is now the fourth leading cause of death of all children in the United States and the third leading cause of death in the 10 to 19. Why? Because one of these disorders has been missed or poorly treated. For sure, alcohol may be a cause for suicide. Firearms, such as in the United States, firearms won't be banned, whatever Mr. Obama says, because of the gun lobby, or social or family problems. But the most preventable cause is one of these disorders. What is the length of time that you need to take these drugs? As I said, about 12 to 18 months, and then you slowly tail it off, keeping an eye on the symptoms. If I have to put this, as I often have to, in lay language, I tell the patient or the family, I say, look, you got a very poisonous snake in your house. You are afraid to kill it, or you don't want to kill it, so you take a broom and push him into a room and lock the door. Now, your question is, when is it safe for me to open that door to see whether the patient is dead, the snake is dead? Well, I don't know. It depends upon how long it takes a snake to starve to death. Maybe a week, maybe a month, it may be 6 months, God knows. So also with these patients. I don't know how long it takes for the disease to burn itself out. You see, what we are doing with these medications is exactly what we are doing with the snake. We put him into a room and lock the door so that he can't harm others or yourself. And then you open the door. You don't fling the door open, lest the snake be alive and jump at you. Similarly, with these medications, you just don't stop it. You gradually drop it. And if as you gradually open the door, you hear a hiss, then you realize the snake is alive and shut the door. And wait another month or so and then open the door gradually. So exactly the same as what you do with these medications. You gradually tail off the dose, and as I said, if there is relapse of symptoms indicating that the disease is still there, then you put them back on therapy. If there is no hissing and the snake looks dead, in the patient's case, the patient looks all right, after about a year or so, then you can take your eyes off the patient and say, look, if you've got a relapse of symptoms, come and see me. This slide is very important, and that is that addiction to these medications does not occur. You have to hammer away, both to the patient as well as the relatives, that addiction does not occur. If you don't, someone in the family will get in the act and say, oh, you may think that you are getting better on the dope that Dr. Senewiratne is giving you. These are not dope. These standard medications. And I tell them, I said, you think it's dope? You think it's a pep pill? Try one of them and see whether the constipation and dry mouth makes you a damn bit better. Or take it to the local pool hall and try and move it. You won't. These are not drugs of addiction. While Valium and all its brothers, Murilax, morphine, codeine, cocaine, all of them are drugs of addiction. The issue of side effects, you have to discuss that in detail. Tell the patient and the relatives all that these drugs will and will not do. Don't let them find out for themselves. If they do, they will be on the horn, mad as hell, saying, look, doc, I got a dry mouth, I can hardly talk. Give me something else, I can't take this stuff. It's impossible for me to function. But if you tell them ahead, look, these medications, particularly tricyclics, may produce a dry mouth. When he gets a dry mouth, he say, yeah, doc did say it'll give me a dry mouth. It has. Perhaps my energy will get better. Here are the side effects of the tricyclics. So I show them all this and say, look, these are the possible things that could happen. You could get a dry mouth, constipation, erection problems in the men, weight gain with some of them. I'll deal with that in a minute. Urinary retention, particularly if the guy has got a prostate, partial obstruction of the prostate, you can end up with a total prostatic obstruction, and I'm very careful in these patients. I keep a very careful check on their urination, or they are dopey in the morning. People say, you know, you can't give medication that makes you dopey. They can't afford to be dopey. He's a banker. Well, it's not necessarily a banker. No one can afford to get dopey in the morning. Not you, not the banker, not myself, nor anybody. If you are dopey in the morning, it means that the patient is taking the drug at the wrong time, perhaps too late, 9 o'clock instead of taking it at 8 o'clock, or even 7 o'clock. They are dopey in the morning, taking the medication at 10 o'clock, I move it back to 9, to 8, to 7, to even 6 o'clock until they wake up. It's all to do with the absorption of the medication. If when they wake up, the blood level is still high, they might well be dopey. And if I really can't get on top of this dopiness, I will change on to one of the other tricyclics or to an SSRI that I know does not make people dopey, but also might well be less effective, particularly in promoting sleep. There is the possible suicide, and I said accidental overdose. What I mean by accidental overdose is that if you are careless with the tablets and patient spills them, and a child sees these tablets on the ground, they look, particularly tofranil, imipramine, looks exactly like Smarties. Picks them up, picks up a handful and swallows it. He probably won't make it to the emergency department. He might well be dead. That's the great advantage with the SSRIs, that even if you take a handful of SSRIs, the chance of dying is probably less. You can die, but less certain than with the tricyclic. So overdose-wise, the tricyclics are less safe than the SSRIs. There is a possible increase in diabetes and this long QT interval, which can only be diagnosed on the cardiogram with the tricyclics. The SSRIs, these are the sort of flavor of the month, and most of the younger doctors think that these are God's gift to mankind, and they will almost always put you on a SSRI and say it's all the older doctors who use tricyclics. These are wonder drugs. Don't believe them. They have their own side effects. They can produce jitteriness and restlessness. They can produce headaches. They can have gastrointestinal side effects, nausea and diarrhea, insomnia. In treating insomnia, the SSRIs are not a patch on the tricyclics. With weight gain, I told you that tricyclics gain weight, so do the SSRIs, particularly paroxetine and mirtazapine, two antipsychotic drugs which I'm not a psychiatrist, I don't use, but I have to deal with the side effects of these two drugs, which is massive weight gain, and the patient hits 175 kg and then comes to me to get the weight down. I put in another rare but very lethal complication of an SSRI, the serotonergic syndrome. This is a disorder which is rare but can be fatal, where the patient is stiff as a board. He comes, you can almost raise the patient by the head. A gross disturbance in biochemical changes in the blood, and if you don't make the correct diagnosis, they well could die. The tricyclics, as the slide says, do not always produce weight gain. In some patients, there can be a dramatic loss of weight because the patient can now focus on the behavior changes, which is what weight reduction is all about. Here is a patient that I was talking about. This patient came to see me at a weight of about 175 kg. He had an affective disorder. I put him on a diet. You can see on the graph on the left, you can't see it too well, but the trouser says it all. He lost about, I think, 100 kg. And you can see the difference in the trouser he wore when he came to see me and the trousers that he's wearing now. And that was on a tricyclic. And they say that the tricyclics put on weight. This is the opposite. And when I asked him how it came about, he said, "Doc, it gave me the necessary energy to stick with your program and to do the 4-kilometer walk that you asked me to do, and that is why I'm losing weight." The low libido. This is the first to go and the last to come back. It is unfortunate that some of the medications too produce a decrease in libido. But I'm very careful to ask, when they say, "Look, my sex drive has dropped off," I say, "Was it before or after the start of treatment?" And they say it was before. Then you can't blame the medication for that. But nonetheless, if the libido problem gets worse, then I have no hesitation in changing on to another medication. The young. The disease does occur in young. For years we were told not to treat the young with medication. Well, I'm afraid there is no other way to treat the young. You can, if you like, the other alternative is electroconvulsive therapy. Very effective, but it's an awful lot of problems. You can break a limb, you need an anesthetist, and again it doesn't last too long. So medication does in fact make sense and well tolerated by children, provided you got the right medication and you're careful in pushing the dose up slowly and keeping an eye on side effects. I'm often asked this question, "She is only young. Are you going to put her on a drug?" My answer is yes, I am. And treat her aggressively too, unless you want to throw her future and her life. I am. She's small. Can we give her a small dose? I said, no. We will give her a small dose to start off with, but if it is necessary, push up the dose to what is needed. And that might be the full adult dose. One way or the other, she has to be treated with an effective dose. We are not dealing with homeopathy and acupuncture and stuff like that. We are treating with real medicine. Pregnancy. These are very common disorders. They can, if they already got one of these disorders and they get pregnant, the dose of the medication might well have to be increased. If they develop one of these disorders during pregnancy and more commonly in the postpartum period, that's after pregnancy, you must treat this disorder with the necessary medication. You say, well, what's the risk of the medication going through the placenta during pregnancy or through breast milk? Yes, some of these do go through the placenta, small amount, and you can get withdrawal effects of the newborn. Rare, but it does occur. You don't want to lie about it and say it doesn't go through the placenta. They can look it up on the internet in any case and find that it does. Or through the breast milk. Yes, tiny amounts do get through the breast milk. But you see, in all of medicine, you've got to ask, what are the risks? What are the benefits? What are the risks of not treating this disorder? What are the benefits of treating it? And in the vast majority of patients, the benefits far outweigh the risks of treatment, whether it comes through the breast milk or the placenta or not. The elderly. This is a common and often missed diagnosis. The price is dreadful. The patients turn up, difficult to manage at home. The fuse is getting shorter, they are irritable, cranky, moody, and often end up in a nursing home where they continue with the problem. The nursing home people are grumbling, the patients are grumbling, the relatives are grumbling. All because you have not made a proper diagnosis. I often go to these nursing homes and see some of these patients referred to me, and I see that at least half of them are suffering from a treatable disease and when you treat them properly, they become far easier to manage, either in the nursing home or even at home. Hospitalization. What about hospitalization? Any form of thought disorder. The patient whose husband died and the patient now hears the dead husband whispering in her ear, saying, "Why don't you come and join me?" That sort of patient has always absolute indication for hospital admission. The other is the patient who, after all my explanation, I've gone through this over and over again, says, "Doc, I'm still not sure whether I won't do it." I say, "Look, please don't. If you get this thought of suicide leaping at you, and it might, just give me a buzz, but don't kill yourself. I don't know whether you're going to be better off where you're going, whether it's heaven or hell or wherever, but I do know that your relatives, your friends, and myself as the treating doctor is going to be devastated by the loss of a fellow human being with a disease that we could have treated." What about the neurotic who uses suicide as a threat? "Doc, if you don't admit me, I will kill myself." What are you going to do? You can't admit them all. And what are you going to do after admission? You're not going to keep them in the hospital. And for how long? For a year? 2 years? 18 months? Today it's difficult to keep a patient in hospital for 18 days, sometimes even 18 hours. Imagine keeping the patient for 18 months, which is the duration of the disease. You can't hospitalize them all, even if they were suffering from these disorders. And these neurotic patients whom I'm talking about do not have a biochemical disorder that you can treat. They are using it as a threat. And this is where the family comes in. They have long since worked out that this guy is manipulating them, myself, and everybody on planet Earth. And that's where they come to your rescue and say, "Don't worry, Doc, we'll take him home. I'm sure he'll be all right." Family counseling. I'm not a family counselor. I don't pretend to be one. But what sort of family counseling is needed? The 4 things are, firstly, education. Indeed, the most foremost thing is education. You educate the family as to what the nature of the disease is. I go over all of what I have just told you with the family, if necessary on a separate consultation. And tell them, look, this is no different from diabetes or high blood pressure or epilepsy. Now, in Christ's time, they stoned epileptics because they did not understand the nature of the disease. They didn't understand that it was the electrical discharge in the brain. And when someone invented the EEG and showed that it wasn't the devil, it was electrical discharge, then epilepsy became an honorable disease to have. And that's what I meant by saying in the last, make it an honorable illness. I'll deal with that in a minute. You've got to stress the point that the cause is unknown. There are a number of trigger factors, but the cause is unknown. If you don't, there will be guilt feelings. The old lady I told you in the nursing home where I made the diagnosis, the relatives come and ask me, "Well, Doc, what is going on?" If you say he's got an affective disorder, it's coming good, and you stop at that, and don't explain the biochemistry, the relatives are going to say, "Well, I know why Granny is withdrawn. It's us. We did not, Granny raised us, worked her fingers to the bone and raised us. And now we are busy with our own jobs and we don't go and see Granny anymore." Rather than feel guilty about it, they are more likely to say, "Oh, I don't think Dr. Senewiratne has really worked out what is wrong with Granny. I think you should go and see another doctor." We don't want any of that. Or a person who has got married 4 or 5 years ago, the wife, active girl who had been running around, suddenly gets moody after attack of glandular fever, sometimes without any precipitating factor, and has difficulty in coping with her work, The husband says, you should go and see a doctor. Come and see the doctor. Doctor says you've got an affective disorder, gives her a pill and says, go and take this, come and see me in a week. And if he stops at that, you're going to lose that woman, because he's going to go back and tell the husband, look, I think, the doctor says that I've got an affective disorder. His first question coming is, what caused it? And she says, medical science doesn't know. I told you, the cause of this is not known. Medical science does not know, that he will not accept. Say, you know, it's me, isn't it? You're not telling me because I'm not earning enough money. Rather than do that, it's better to give a biochemical explanation to the patient, who can then relay to the husband. You got to counsel the family that it is not a sign of chronic weakhood. Make this disease an honorable disease, as I've just told you. It can strike anyone. And when someone says, as the next slide, I'll show you in a couple of slides, I'm not the sort of person to get these affective disorders, it means that the patient has not understood the nature of the disease. What about hereditary factors? Do I discuss them? I sure do. You see, if you blame the genes, rightly or wrongly, then they can pass the blame up the ladder. Grandmother, great-grandmother, oh, so you don't think it's we who have done this? Oh, I say, no, it could be the genes. Then they'll defuse their guilt feeling, and if they're happy with that, that's fine. Here are some comments from patients that must be addressed. Here's one comment, so you don't really think there's anything wrong with him. You think it's all in his head. Stop them right there and say, no, I don't think we are talking about the same disease. It is not all in his head, such as what you are implying. It is in his head, but not the way you are thinking about. Doc, he is someone who does not like to go and see doctors. Well, nobody likes to go and see doctors unless you are trying to manipulate the doctor to get a sickness certificate or to just come and have a chat, which some of these old ladies do. And it may not be covered by Medicare, but it serves a therapeutic role to have a chat with these elderly people. The other comment, which I've already alluded to, I am not the sort of person to get these disorders. This means that there are certain people who are prone to develop these disorders. There aren't any more than there are certain people who are prone to develop epilepsy, unless of course you've had a head injury, or to develop the leukemia or the lymphoma. There aren't any particular type of person. Anyone can be struck down with this disease, if often with a genetic background, sometimes without a genetic background. But anyone can be struck down. You've got to make it an honorable disease. The next question I'm asked is, can we take him to a psychologist? I say yes. You can take him to a psychologist. He can psychoanalyze you till the cows come home. When I qualified in medicine 50 odd years ago in London, we didn't know all this, all the affective disorders and the neurochemistry. Psychiatrists who taught me put the patient on the bed and psychoanalyze them from 60 to 50 to 40 to 30 to 20 to 10 to 5, and found that he had been locked up with the spiders in the closet, and that was the trigger factor that finally ended up with an anxiety disorder. That's all nonsense, you know. That's not true. He may have the spiders may have scared the hell out of him, but that wasn't the cause of what he's suffering from now. I'm not running down the psychologists. They can address certain problems, and if they can, for example, if you can prove that the trigger factor was a best mother-in-law moving in and he can do something about it, or he can diffuse some guilt feelings, that's fine, as long as he doesn't interfere with the treatment which I will do. It's exactly like obesity. I told you I have an interest in obesity. Often the question asked is, can we put them on a weight reduction regime? The intake I fixed, the exercise program I fixed, the weight's coming down, patient doing well. can we see a dietitian? I say, yes you can, by all means. She can do what she likes. She can give you vitamin A, B, C, D, E, F, G, anything. Cobalt, cadmium, zinc, omega-3, omega-4, anything. But please don't tell her to interfere with the diet and exercise program that I have put you on. I will do that. I've said that this is the most rewarding disorder to treat. You know, a lot of doctors avoid seeing patients like this, saying that they are a pain in the neck. Some of them are, but the majority of them are a pain in the neck because the doctor does not understand the nature of the disease. Sure, the neurotic who tries to manipulate you is a pain in the neck. And if you can get rid of him, by all means do, but you can't. Unfortunately, you've got to suffer him. But the vast majority of these patients are not a pain in the neck. They are some of the most rewarding people to treat. And in the past 50 years that I've been a doctor, they are some of the people who are most grateful to you. Here's a person who has lost all hope. He's about to blow himself away. His quality of life is zero. He feels that he's useless. He's of no use to himself or planet Earth. And you then make the correct diagnosis, put him on the right treatment, and he comes good. And you give him a new lease of life. They are grateful to you for all their lives. Not that you need gratitude, but you feel happy that you have at least salvaged one human being. Thank you very much.